Over to you, sir.
Okay, thank you. Hello, good evening, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar, as you know, is brought by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993 with 30 years of excellence, 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Hetero Healthcare is the largest closely held pharmaceutical company in India and is amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Hetero Healthcare has Asia's largest API manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India, wide product range encompassing multiple specialties, pioneering in quality and innovation, and distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patient, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Pramod Zog sir as moderator and Dr. Sebaranjan Biswal as speaker. Welcome, Dr. Zog. Welcome, Dr. Sebaranjan. Dr. Zog is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI, CSO 2016-19, Chairman Mini Recipe Module IIP, author of book Cophology. Dr. Sebaranjan is Professor and Head of the Department of Pediatrics, KIMS Bhubaneswar. Sir is Secretary General, Odisha State IIP 2021-22, CIP EB Member 2024. Welcome, Dr. Sebaranjan. With this brief introduction, I hand over the session to Dr. Pramod Zog. Over to you, sir.
Thank you. Okay. Are you able to see the slides, Sevaranjan?
Yes, sir. Yes, sir.
Yes,
Clearly.
Okay, very good. Okay. So, good evening, friends. I am Dr. Pramod Zog, pediatrician from Pune, and I have great pleasure in having this particular discussion related to the use of oseltamivir in the management of influenza. And I'm so glad to have Dr. Sevaranjan Biswal, and both of us will discuss quite a few different aspects of flu and management of flu, along with early use of oseltamivir in influenza. As you can see, the influenza virus is usually the one which has a particular nomenclature, and I have tried to put my name in the fashion of influenza virus, like the place of origin and the year of origin and so on. And I was the presidential strain of IIP in 2016, because everyone knows that IIP presidents, they keep changing every year, like the influenza virus. Anyway, that's in a lighter vein. And basically, influenza is a disease which is very common in the period of monsoon, and the period of monsoon varies in different parts of our country. In certain areas it is during, say, June, July, August and September. In some places it is by the end of the year, like in November and December. And these illnesses like influenza or respiratory syncytial viruses, they usually produce respiratory infections, and they are very common during the months of monsoon. And many times our colleagues are confused whether the respiratory infection which they are treating is bacterial or viral. And many times it leads to misuse of antibiotics, because there are no clear cut guidelines about the information about differentiation of these two illnesses, unless one is well versed with the clinical differentiation. Long back, I was not much worried when someone used to say that this is a viral infection, because at that time we all were, under the impression that viral infections means, a course of 3 days or 5 days, and the child would recover. When we used to say flu, people used to think that it is nothing but, a bit of cold which is going on for a long time, maybe a different type of a cold. And when we used to say viral, people were not much worried. But after the pandemic of influenza in 2009 and the COVID pandemic in 2020, 21, 22, now we have changed our view, because we have seen that in the beginning the picture may be mild, but after 4 or 5 days sometimes there is cytokine storm. And influenza is known to be a biphasic illness. And what happened was, during the period of COVID, many children remained indoor. They did not develop the immunity against some viruses, and that's why once COVID started declining, all the viral infections, they started showing up. So in different parts of our country, we saw influenza epidemics, we saw RSV coming in a big number, we saw hand, foot, mouth disease coming in a big number, and this was all because of what we call as immune debt. That means, the children who did not develop immunity against particular viruses. And in the post-COVID period, we are also witnessing that the older children are also getting affected. So we will start the discussion with a case, which is a 3-year-old boy who came to us with fever, cough, cold, and progressive breathlessness over 3 days. The child was tachypneic and was hypoxic, and the X-ray of the chest showed ARDS-like picture. Obviously, the child was sick, serious, and was admitted to the PICU, was ventilated, and received oseltamivir along with supportive treatment. And H3N2 was positive from the throat swab. The child was ventilated for 3 days, and then the child improved. Now, the question was that in a previously healthy child presenting with cough, cold, and fever and progressing over 3 days, whether the treating clinician could prevent this particular progression, and whether every patient of cough, cold, and fever be given oseltamivir upfront in the flu season. So there were quite a few points which were, like confusing points, and as they were the points of confusion connected with flu, I have written it as confusing points. Okay. So as I said earlier, whether it is bacterial or viral, if it is viral, what is the type of virus, whether it is rhinovirus, adenovirus, or influenza? And if it is influenza, whether it is H1N1 or H3N2, and whether I should start oseltamivir upfront. So all these points need to be discussed in details. And we are all aware that in monsoon, there are quite a few healthcare related challenges. And there are some illnesses called as influenza like illnesses, or ILI. And influenza is, the father of all those influenza like illnesses. I say this because the presentation of influenza is many times, with lot many systemic presentations. For example, a child might have high fever with chills to begin with, headache, child might have severe weakness, pain in the muscles, and the presentation is, something which is not a very, very mild viral infection. Of course, whenever the onset is with cold and cough, it's, something which is respiratory in origin and viral in nature. But as I said earlier, the viruses are changing their nature, and that is why sometimes in the initial part, the presentation may be mild, but later on they may take a different turn. And the mortality of influenza is also rising over last few years. One should also know a bit of the details about the types of influenza viruses. I call this as KYC of the naughty influenza, because it's the know your customer. We should know our enemy, that is influenza. And why naughty? Because it's an RNA virus, and RNA viruses are known to change their structure every year. Influenza A causes frequent epidemics, and this is because of the minor antigenic variation in the amino acids in the outer part of the virus. And it also produces periodic pandemics due to major antigenic variations. This influenza A can attack birds, animals, and the human beings, but influenza B infects only human beings. Now, when a virus attacks different species like birds or animals or human beings, what happens is that the virus from the bird and the virus from the human beings together, they try to go to the pig, for example, and try to, go into a different, totally different kind of a virus after mixing, because then these animals like pig, they act as mixing vessels, and a totally new virus, for example, the one which came up in 2009, and that's why it was called as a swine flu virus, because swine means a pig. So people did not have immunity against that particular novel influenza virus, and that's why it led to pandemic. This is known for influenza A, and four major global pandemics have occurred till now. And influenza B, on the other hand, as I said, infects only human beings and causes local epidemics. It doesn't produce rather pandemics. Now, on the outer side of the virus, there are these two important glycoproteins, hemagglutinin and neuraminidase, of which hemagglutinin is basically the molecular key. What it does is it allows the influenza virus to get attached to the respiratory epithelial cell. The RNA inside the virus gets an entry into the respiratory epithelial cell, and there it multiplies, and the RNA produces different copies of similar nature. In fact, this RNA of the virus dictates the DNA of the host cell to produce similar copies of RNA. And once so many copies are produced, they are then released inside again from the respiratory epithelial cell to attack other respiratory epithelial cells. And this particular release of these RNA virions is blocked by oseltamivir. So this particular neuraminidase is inhibited. What does neuraminidase do? Neuraminidase acts like a molecular scissors. That means it literally cuts all those virions into different parts, and neuraminidase is the one which is responsible for releasing those virions again from one respiratory epithelial cell to other cells. So this particular process is blocked by oseltamivir. That's why it is called as a neuraminidase inhibitor. As I told you earlier, there have been four major global pandemics, and that way, like in 1918, 1957, 1968, and 2009. Every time they were either because of H1N1 or H2N2 or H3N2 or H1N1. So all these have been major global pandemics. So, with this particular background about the virus, Dr. Sevaranjan, uh, I have some, question for you, and that is about, the update about the epidemiology about these circulating strains of influenza viruses, which are affecting the pediatric populations in India. So maybe in Bhubaneswar, maybe you might have come across different types of viruses. So what's your experience in your area?
Basically, whatever the recent updates, the mainly H1N1 and H3N2 are the
Yeah.
two major strains which is occurred in the community, and whatever vaccinations available in against the strains also it is prepared.
Okay.
So mainly we have to see about these strains are very common in circulation now in our community. H1N1 and H3N2.
Yes.
And basically influenza type A is the most common. And very in a less condition you can get influenza B. And whatever the pandemics occur due to this antigen shifts in basically due to type A influenza. And basically the incubation period is very short, like 1 to 2 days or 1 to 3 days or 4 days maximum. So that's why sometimes when the child comes with a sudden onset of fever, cough, or running nose, and with respiratory distress. So we have to very much aware about this condition. The child comes very with short span of time. Child comes with respiratory distress with these following symptoms. We may think that maybe it might be due to this influenza. And in compared to other conditions like COVID, other things, which have little bit longer incubation period. So it will not occur so early. So though whenever we are not sure about this thing, sometimes to get it to diagnosis with the laboratory helps. So it takes time. So that's why sometimes whether we give the antiviral or not. So that's why we have to see what is the clinical course of the disease, and we always follow the progress of the disease. That is more important. How early the child is progressing, the disease is progressing. So accordingly, we have to think that whether it is due to this influenza virus or any other viruses.
Sure. Yeah, that's something very important. And I always believe that the patient who comes to me on day one is usually, asked to come back again after 4 or 5 days, because as you rightly said, the follow-up is very important. And, many times people take, influenza very lightly. And that's why we have to inform them that you have to report after 4 or 5 days. In fact, in my practice, I do not charge them for the follow-up, because many parents are worried whether I will have to pay again. And, that's one of the inhibiting factors. They feel that, they will have to pay again. So they remain at home. They will say, let us wait, let us wait. And in that, many times the illness also becomes serious, and child may come at a late stage. So many times, you see the child on day one, and then again after 5, 6 days in a serious state. So what you have said is very important, that the follow and whether the child is progressing from cough and cold to respiratory distress is something one must be very vigilant about. And as we know, this virus spreads by respiratory droplets. And these droplets, basically, when a person coughs or sneezes or talks, they are released and they land in the mouth or the nose of the people who are nearby. Or, possibly they are inhaled into the lungs of the person in front. And then the journey of this particular disease begins. In your practice, Dr. Sevaranjan, what all clinical scenarios have you seen, particularly during this season or maybe over last few years? What is your clinical experience?
Okay. So in the picture of the COVID, SARI or any influenza, the main thing, the common thing is just viral infection. There will fever will there, myalgia will there, rhinorrhea, sore throat, cough may be there. But the thing that we are not thinking of our influenza, probable case, we will take some history about the history of contact with the person who is suffering from influenza in the family or nearby, whether the child is migrated from places where the incidence of influenza is there or epidemic is going on, or like this, you have to take the history. Accordingly, we can suspect the child may have influenza. Otherwise, in clinical point of view, the acute onset of fever, cough, sore throat, rhinorrhea, malaise, myalgia, and headache, along with there is sudden development of respiratory distress. So that imply that the child may have influenza. And
Right.
sometimes it may be associated with other system feature, as if you differentiate between the acute viral infection and bacterial infection. So in viral infection, the fever is very high grade at the onset and gradually decreases by the 3 to 4 days or 3 to 5 days. But in bacteria, it starts with low grade, gradually increases by 3 to 5 days, it may be high. And second thing, if there is any only one system is involved, is bacterial, and it is localized. Where the multiple systems involved, like there is rhinorrhea, and there is with gastroenteritis, all the things, always we think it may be a viral origin. And interfluenza period, if the child is playful and doing well, we may think it is viral. If the child is looking sick throughout the day, we may think bacterial. And in spite of all the things, whether it is a bacterial pneumonia or viral pneumonia, whatever may be, as per the guidelines or British guidelines, we have to treat the antibiotic because we know the influenza virus, the hemagglutinates, what are told, so that will do the adhesion and invasion. But ultimately, the virus will not do any pathogenesis. What are the pathogens usually occurs or complication occurs because of bacterial complications. So secondary bacterial infection leading to complications like pneumonia and ARDS, all these things are there. But usually the virus only just leaks, but the pathogen is caused by the bacteria. So that's why always we have to treat accordingly of the after antibiotic as well as viral limit the release of virus by inhibiting the neuraminidase will be helpful.
Sure. So you have given a detailed information as to how to differentiate the viral infections from bacterial, and it's very important to understand that influenza is a viral illness, and that is why many times, in addition to the respiratory features, the child can have gastrointestinal symptoms like vomiting and diarrhea, because viruses involve more than one system, and we have seen that there are certain emergency warning signs. And as Dr. Sevaranjan told us, when a child comes with cough and cold and then develop fast breathing or trouble in the breathing or becomes cyanosed or doesn't drink enough fluids or basically remains irritable or sometimes flu-like symptoms which improve and again return, or if there is worsening of the cough, then parents also should be made aware that these are what are called as red flags. And that is why, unless you tell them, they won't understand. Otherwise, they will feel that, oh, Dr. Jog has examined and Dr. Sevaranjan has seen my child and they have asked us to give these medicines and that's the end of it. But no, whenever a child has rapid breathing, when the abdomen is moving very, very fast, or if the child is really not accepting feeds, it means that these are certain things where parents have to be very, very aware. Why this is important? Because the molecule oseltamivir has to be given very early. In case if the child is progressing to seriousness, then early use of oseltamivir will prevent the further progression. And many of our colleagues and the family physicians are not aware of this fact. So what they do is, worsening means give antibiotics. Okay, they never think of giving antiviral. Okay, and that creates a problem. Remember, 90% of the infections in the practice are viral, whether it is gastroenteritis, whether it is respiratory. And in the viral, as we said earlier, there are some points we should know whether it is bacterial or viral, and if viral, whether it is something like different type of virus, non-influenza virus or influenza, because influenza is the only treatable condition where you can have some antiviral like oseltamivir which can help you. And I always say that there are some complications of flu which start with the alphabet A. For example, ARI. Influenza virus can attack the respiratory epithelial cells directly and produce primary viral pneumonia, or it can produce ARDS as a result of cytokine release. It can also complicate, in the acute otitis media, because the bacteria like Streptococcus pneumoniae or Staphylococci, they will produce secondary bacterial infection, as Dr. Sevaranjan just told us. And because of the illness, the child would remain absent from the school. The parents also will lose their daily wages, and as we have been discussing right from the beginning, it is one of the causes of antibiotic abuse. And that's why people will tend to give the antibiotics. Now, Dr. Sevaranjan, we all are aware of categorization of influenza into categories A, B, and C. So, for the benefit of our listeners, I will request you to just tell them about the categories of influenza.
So category A basically uncomplicated and mild. The patient's mild fever, cough, and sore throat, without the body ache, headache, or diarrhea, and vomiting. Only that is only just like a cough and cold and mild illness. And category B is those that are having high risk and severe symptoms. That this includes patients with high grade fever, severe sore throat, additional category A symptoms, who may need home isolation, and with the you can give oseltamivir. It also includes individuals with category symptoms and pre-existing high-risk conditions such as children less than 5 years. So always you have to think some of the special groups like pregnant mother and infant and more than 65 years of age. Those are high-risk patients. So those are less than 5 years or especially less than 2 years of age, pregnant over 65 years, or having chronic health, either any kidney disease, or chronic lung disease, chronic liver disease, or chronic heart disease. So any chronic conditions, these are high risk patients, and you have to treat according. You have to think of them, and you have to give the prophylactic oseltamivir. In category C, it is severe disease. This category includes patients with category A and B symptoms, and who also exhibit severe signs like breathlessness, chest pain, drowsiness. That means that is severity means that it may be encephalopathy, there may be involvement of the ARDS like this. So in this condition, and there is a difficulty breathing and the child is having features of all the respiratory distress. These are on category C. So
Sure.
accordingly to the severity of the disease, you have to categorize whether it is a mild or severe symptom or severe disease. So accordingly, we have to categorize into three categories.
Sure. Excellent. Before we proceed to the management, I will just tell you a bit about this molecule oseltamivir. As I told you, it blocks the viral neuraminidase enzyme, which is critical in releasing virions from the infected host cells. Actually, oseltamivir is a prodrug, and that gets converted to the active form, oseltamivir carboxylate, in the liver. And this was the first oral neuraminidase inhibitor, and it has been approved in more than 100 countries. And the CDC, American Academy of Pediatrics, have approved this molecule. And now, depending on the categories A, B, and C, the treatment guidelines have been formulated. And these are basically the treatment guidelines for influenza-like illnesses. So, when the patient has mild presentation, then only home isolation and bed rest, along with plenty of fluids and paracetamol for fever, are enough. Remember not to give aspirin, because aspirin is known to produce problem like Reye syndrome, which is seen, in patients, particularly of influenza B, after salicylate exposure. When the child is a bit serious, one should always think of giving antivirals in addition to the isolation and bed rest and plenty of fluids. And once you start oseltamivir within 48 hours, it helps in different ways. We will discuss what are the ways in which it helps. Okay, these are the patients where you may go ahead and do the testing if the facilities are available, but that is something which is not mandatory. The clinical judgment is more important. And when the child is much serious with distress and hypoxia, it is necessary that you admit the child, do the nasopharyngeal swab, test it, and give the therapy with antivirals and supportive therapy. So, depending on the respiratory rate and distress and seriousness, our colleagues can classify the illness into A, B, and C, and it is very important to convince the parents also. They just discussed about the categorization and the management dependent on the categorization. So I would just like you to tell our audience as to how the early initiation of oseltamivir influence the clinical outcome, like duration of illness or progression to severe disease and complications. And secondly, whether we can give oseltamivir for a child who is admitted with low respiratory tract infection with distress, and who is H1N1 or H3N2 positive on day 4 or 5 of illness. That means he comes little late. Then whether we can give oseltamivir, even after day 4 or 5 of illness.
Okay. First of all, you have to the disease oseltamivir, the drug oseltamivir is helpful in the decreasing the complications, decreasing the progression of disease, allow the antibiotic use also. So basically, in the early part, when you like immunosuppressor, it will also help in the reducing the release of the virus. So that's why the transmission further infection decrease. So disease progression decrease in this way. So for diagnosis of this influenza, we will take the RT-PCR, and sometimes depending upon the site of infection, whether it is upper respiratory infection or lower respiratory infection. Secondly, we have to take throat swab or the nasopharyngeal swab or for the bronchoalveolar lavage, whatever may be, depending upon the site of infection, we have to choose, and getting the report also late. So that's why starting the Oseltamivir in the early, within 48 hours is best. But if the child comes after 4 to 5 days with illness and we diagnose, that also helpful in the retardation of the disease progression. So that's why even if it after 4 to 5 days of fever, you are able to diagnose, and you can give Oseltamivir at that point. So in this Oseltamivir within the first 48 hours reduces the illness of the duration by 1 to 2 days, decrease the risk of complications such as pneumonia, encephalitis, secondary bacterial infections, and lower hospitalization rates. So early treatment is associated with much better recovery and fewer long-term sequelae in the lung. For IPD patients, studies have indicated that Oseltamivir can be started as late as 4 to 5 days of illness, and it reduces the disease severity and helps in preventing the complications. So that's why even if late also, you can start and you can give.
As you said, about the early initiation of therapy, there are many clinical trials which have shown that, empiric treatment is strongly recommended, and the treatment should be started as soon as possible. And the laboratory confirmation of influenza virus infection is not necessary for initiation of therapy. Because many times, if the technique, is not very perfect, sometimes H1N1 or H3N2 is not detected, because there is a definite way of collecting the throat swab. And sometimes, if the technician is not very skillful, sometimes it happens that the child has influenza, but the laboratory report of the throat swab comes negative. So the point is that when you clinically suspect influenza with all the symptoms that we discussed, then it is prudent to put the child on Oseltamivir, because Oseltamivir is of greatest help when given in the first 48 hours. That is the most important thing that our listeners must remember after today's discussion. Now, Dr. Sevaranjan, we have a few cases which we encounter commonly in our day-to-day practice, and in case if these cases come to our OPD, we must be equipped with the information about the approach to these patients, how to answer the parents, what should be the strategy of management, and that's why these 4 or 5 cases will help our listeners to approach and manage the cases better. So this is a child who has come to us with fever for 3 days, cold and cough, and he has been on metered dose inhaler since 4 months. He is well controlled, and he has received symptomatic treatment, and he has come back after 3 days. He remained afebrile for a day, and the fever came up again. In between, he has been quite active. Okay. These things are now very common. As we all know, these are cases of recurrent viral upper respiratory infections which have become very frequent, and they are occurring at a shorter interval. So parents many times ask us whether antibiotic is necessary. So in your practice, how would you counsel parents of children presenting with such an illness?
Okay. As you told, the fever is for 3 days, and with the associated cough and cold, and the active in between the febrile episode,
Right.
which show that the child may have viral illness because the child is active in between the interfebrile period, and child has MDI since 4 months. That means existing respiratory disease there. For that reason, the child is getting special. So which implies it may be asthma, or it may be which whatever may be. We don't know, but ultimately, the child has some pre-existing respiratory disease. So, and that is also well controlled with this MDI, and the child is having the again fever after 3 days. That means that will it record once again. So it also implies that the child may fever. And usually in our clinical practice, when the child comes with fever, at least 2 to 3 days, we don't have any laboratory test. Usually we'll think in the line of fever at the viral origin. So that's why we're not doing any laboratory test. After 3 days of fever, if the child is persisting with fever, then we may think whether it is bacterial viral. Sometimes the medical science is not like the mathematics. Sometimes it may not be holds good. So sometimes we have to do the test to find out whether it is bacterial viral. So as you know, when in the influenza also, when the existing disease is there, so it will be more severe after this influenza infections. And if you see the influenza also, after influenza also, there may be chance of pneumonia due to bacterial invasion. And sometimes even necrotizing pneumonia may be happens with previous bacterial influenza or adenovirus infections. So that's why we have to approach accordingly at the symptom of the child, whether the fever is subsided completely after 3 days. That means we will think if the fever is there, it is no more. But when it arises after some gap, we may think a secondary bacterial infection may be there. So accordingly, we have to investigate to find out whether the bacterial viral. By doing simply CBC and the CRP, we can differentiate. So
Yeah.
accordingly, we will
Uh,
treat.
right, right. And of course, I'm sure we would also counsel the parents not to worry because we all know that 6 to 8 viral infections in a year are common, and
Yeah.
children need not be unnecessarily put on the antibiotic therapy, provided clinically we find that this child is a case of viral infections. And repeated viral infections are very common. And in my practice, what I do is I also maintain the growth charts of these patients. Okay, so when you show that the child is, growing well and weight is increasing, then the parents are convinced that underlying there is no major problem, because if the child continues to have some major problem beneath, then the weight gain will suffer. So I usually have put up a big growth chart on the back side of my consulting chair, and I just show them or point them, see the growth of the child. The child earlier was 10 kg, now he has gone to 11 kg, so there is a regular weight gain. So why are you worried? So once you spend a bit extra time with the parents, they also feel convinced, and they don't insist on the antibiotic therapy. Okay. And in fact, one of my friends, Dr. Anil, from Bangalore, he tells the parents that, see, you have to now consider cold and cough as an extra member of your family. Okay, till your child grows, this cold and cough also will continue as a member of your family. And don't worry, there is absolutely nothing to worry, because the child is growing well. Okay. And our colleagues also should know as to what are the clinical clues for identifying certain organisms. So rhinoviruses, the onset is with cold and sneezing, and usually it's a virus which affects the upper airway. Either there is mild fever or no fever, and there is no exhaustion, and children play well. Along with high fever, if there is prominent headache, myalgia, and extreme exhaustion, one should suspect flu. In case of adenovirus, the presentation may be with pharyngoconjunctival fever or diarrhea or mesenteric lymphadenitis or hemorrhagic cystitis, though adenovirus is basically a respiratory virus. And then under the age of 1 year, many children with RSV, they come with bronchiolitis. And for the bacterial infections, there could be some clues. Like, for example, if the child has fever with follicular tonsillitis and tender cervical nodes, one can suspect group A beta hemolytic streptococcus. If the child has fever, grunting, and tachypnea, one can suspect pneumococcus. If there is rapid progression and the child is toxic, one can suspect staphylococcus. And if the child is above 5 years with predominant cough, then one can suspect mycoplasma. This is what I called as educated guess, so that the practicing pediatrician can get an idea as to what I am probably dealing with. This was another case. He was a 4-year-old child with cough and fever of high grade since 5 days. He was not settling with oral medicines, and on admission he was tachypneic and needed oxygen support. You can see that there are infiltrates on the right side, and the hemoglobin was 11.6. The total count was 1620. The platelets were 132,000. And there was, mild increase in the SGPT and the SGOT. And the nasopharyngeal aspirate was positive for S3N2. So we diagnosed it as a case of influenza with low WBC count and low platelets. So if such a child comes to you, Dr. Sevaranjan, how would you approach, such a child who has come to us, with presentation like cough and fever of high grade, and who needs oxygen support because, he has tachypnea and problems, which I just told you.
As the child comes with after 5 days of fever, 5 days fever, and having a rapid progression of the distress and needing oxygen requirement. So in the end, on X-ray, there is some heterogeneous opacity there in the right lung. That indicates that there is, uh, as per the history, it may be viral infection. As the investigation also, it shows there is a, from nasopharynx it is isolated, the H3N2 is isolated, and there is a leak of pneumonia along with thrombocytopenia, as well as increased liver transaminase, and it shows that the child have some viral infection, along with there may be secondary bacterial infection. So in this condition, we will treat. So first of all, the supportive treatment should be given to calm child in the form of the oxygen should be given, as well as for nutrition, what the child is taking orally or not, accordingly, high fluid, other things can be given to maintain the fluid electrolyte balance. Along with, we have to start the our anti-viral therapy. Oseltamivir should be given, and by along with we can add some antibiotic also. Because we are not sure about the secondary infection of the bacteria on this viral infection. That's a way to start with the antibiotic along with this. So and supportive like antibiotics should be given as far as this.
Right. So that's a very good approach. One must remember the categorization that we discussed, and obviously from the presentation, this child goes straight away into category 3, and that's why the investigations like the nasopharyngeal swab and putting the child on oseltamivir are perfectly rational as regards the approach is concerned. In the monsoon, many times we get children with dengue who also have thrombocytopenia and leukopenia and transaminitis, and that's why it's prudent to also keep a watch whether this particular child is getting into some other complication. And in case if one strongly suspects dengue, there is no harm in going ahead and doing certain tests like NS1 antigen for dengue also, because sometimes we do see co-infections of influenza with dengue, and even sometimes with RSV also we get children together. And one should always remember that these children who are hospitalized, okay, they always need to be put on oseltamivir. Very important. Hospitalization, yes, you must think of starting oseltamivir. There were a few cases which came with H3N2 positivity with similar presenting features. In some, the CRP was a bit on the higher side. Of course, one of the patients deceived us. In this child, the WBC count was high, the CRP was high, and the fever was very continuous and high fever. Okay, this turned out to be a case of adenovirus positive. And one must remember that adenovirus many times comes with lobar consolidation, which mimics our lobar pneumonia, and one should be aware of these facts. Another virus which can deceive us is human metapneumovirus, which can also come with lobar pneumonia. Then Dr. Sevaranjan, this is another child, a 5-year-old girl, which came with high fever for 5 days, cough and cold for 5 days, and the child was sick. There was mild wheeze. There were no crepitations. So with similar picture like this, will you put this child on antibiotics, or will you just continue with paracetamol and some antihistaminics? So how would you approach this child on this history and examination?
So the thing that in this condition, 5-year girl with fever, cough and cold for 5 days. So fever is there, cough and cold also there, and child looking sick. So if the child is not always sick, he is playful in between the interval period like this, we may think of it may only purely viral. When the child looking sick, that means always we can think of there may be some better component there. So the mild which is there because of the either may do some obstruction to the airway or like what maybe, and there is no crepes, that means there may be no evidence of any consideration like this. Only there may be some obstruction due to say infection or intraluminal blockage due to mucus or any infection, whatever may be. There is some obstruction to the airway leading to this wheezing. So it is 5-year girl. So basically, if you see about the as a sir told uh, about the causative agent. So RSP usually in the infancy. So it is not the cause in the this 5-year phase. And when it 5-year phase, we will think of any flu like this which may cause these things. And in this condition, we have to as the child with started with high grade fever at the beginning, we are thinking of viral only. So we have to start with the antiviral along with about the antibiotic. So if the child is sick, we can add and uh, and the child is we have to see what is the progress of the disease, how the disease is progressing, what the child is improving with time period or deteriorating. Accordingly, we have to think of antibiotic. The child disease is progressing, so we have to start the antibiotic along with this antiviral.
Right. Okay, that's very nice explanation. So this child was put on amoxiclav. The WBC count was 2800. The CRP was 34.7. This child was put on oseltamivir, and the nasopharyngeal swab somehow showed rhinovirus positivity. Many times it so happens that some of these viruses are detected as, innocent bystanders. They are simply present over there. But if the clinical presentation is suggestive of influenza, it is better to continue with oseltamivir and not to discontinue the antiviral agents, because many times, in the epidemiological setting, if a child has fever, cold, and cough, then it is prudent to continue with oseltamivir, which has already been started. The sensitivity of influenza PCR is quite good. It's above 90-95%. And that's why if the test is positive, then there is, little doubt that it is not, influenza. However, if the influenza test is negative, then as I said earlier, sometimes it so happens that, the technique of collection of the nasopharyngeal swab sometimes is not very skillful, and that is why sometimes the report comes negative. However, in case if you go clinically, then if you suspect influenza strongly, it is better that you continue with oseltamivir. And these are some important points related to the PCR. Dr. Sevaranjan, in your place in Bhubaneswar and in the medical institute where you are attached, are you able to get the reports of these nasopharyngeal swabs, whenever you demand, and how long does it take? So, what is your experience?
Basically, in our institute, we have molecular lab, so they are doing in a day. There's no problem in getting it. And
Okay.
sometimes the RMRC, if you're sending, those are we are giving it free. We are sending to RMRC. Sometimes they are giving in the 1-2 days. They are giving the reports.
Okay. So, and is it a routine to send the samples for nasopharyngeal swab testing?
It is not routine. Suspected cases only we are sending, not in all cases.
Okay. 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 Uh, There is another child who is a 7-year-old daughter of the IT sector parents. These are the parents who are highly educated, and even for the slightest complaint of fever, they will rush to the pediatrician. Of course, this girl had high fever for 3 days, and the child had examination 2 days later. The child had only throat irritation, and examination revealed mild congestion in the throat, and that's why she was put on paracetamol. And flu and other viruses were, seen in the atmosphere at that time. So the parents were concerned about many things, and they wanted us to tell whether these investigations are necessary, whether throat swab is necessary, whether one should put the child on empiric oseltamivir. So when such a child comes, what is your lookout? How do you speak to the parents, and what do you do?
As flu and adeno is around, so it is one of the definition of probable influenza, a
Okay.
probable case of influenza, as there is history of the flu and adeno around. So that's why when the child comes with sudden onset fever with cough and cold, with throat irritation and mild congestion in the throat. So in this situation, we can exclude the presence of flu or the flu infection by doing the RT-PCR, and as well as they are highly very much worry about the child. So to negate the bacterial infection, sometimes CBC will do after 3 days of fever. Now already 3 days of fever is there, so we can do it. And oseltamivir empirically we can give. If it is negative comes later on also, then no harm. So we have to empirically we can start with the oseltamivir.
Okay. Many times it so happens that, for example, in this particular child who was a 3-year-old boy who came for cough for a week and high fever and crepitations, and was put on, co-amoxiclav, and was admitted for persistent fever, and put on this IV medication. The investigations, hematological reports were almost normal, and throat swab showed influenza A. Okay, so already the child is on amoxiclav, but the hematology doesn't support bacterial infection. On the other hand, it is showing influenza A in the throat swab, and that's why oseltamivir was added. So it becomes a dilemma for the practicing pediatrician, whether to continue with this antibiotic which was started, or whether we should stop it. So how would you look at this situation? What do you think?
So though we started the antibiotic initially, it is better to complete a course of antibiotic because we started early, then done the investigation later on. Even if we this is one of the also. So that's why we can give oseltamivir along with the antibiotic which you have started. You should at least complete at least 5 days of antibiotic therapy.
Okay. In case if the child remains to be, afebrile, and if the child doesn't progress to any complication, it is prudent to continue with oseltamivir alone. Sometimes it so happens that the laboratory parameters are not supporting bacterial infection at all. So in that case, depending on the clinical situation, depending on the clinical picture of the child, many times we have to take individual decisions based on the clinical presentation of this child. Okay, and we
Yes.
should also remember that there is something called as antibiotic stewardship, and that's why when the reports are in favor of viral infections, and if the child is doing very well and doesn't have fever, then maybe one can stop the antibiotics, at least not to escalate the uh, antibiotics, and observe. Clinical observation is supreme. Okay, of course we have had quite a few cases with neurologic complications, and many of them presented with simple febrile convulsions, and there were a few cases which came for influenza associated encephalopathy and case of acute necrotizing encephalitis. And fortunately, this child, was saved, because as all of us are aware, some of these conditions have a very high mortality. As I said, some cases came with co-infection with RSV, and there are some respiratory complications which we have not touched upon. One of them is exacerbation of chronic pulmonary conditions like asthma, particularly in children above 2 years, and in the hospitalized patients. Okay, there have been reports of complications like toxic shock syndrome and cardiac complications like myocarditis. I remember a case where the tachycardia was disproportionate to the fever, and then we were able to diagnose myocarditis. Of course, these complications are rare, and there are some children who, particularly the boys in the age group of 6 to 9 years, who come to us with bilateral gastrocnemius and soleus involvement with severe calf muscle pain and inability to walk. They are the ones who are having myositis, which is more common with influenza B. And as we said earlier, this Rye syndrome, which is nothing but, akin to liver cell failure in children who are exposed to salicylates, particularly children with influenza B. So there have been these complications which have been reported, witnessed by some of us, and some of our intensivists also have seen some of these complications. There are some rapid questions, Dr. Sevaranjan. There are two siblings in the same family, and the elder one is admitted with influenza A, and the younger one has developed fever yesterday evening. Okay, the age of the elder sibling is about say 2 years, and the younger one is 8 month old. So, what would be your strategy as regards starting oseltamivir? Will you put this younger one on oseltamivir?
Yes, sir, because as you know, there is contractility positive and the incubation period is 1 to 4 days, and the child has the symptom from this elder brother. So we have to start the Oseltamivir.
Okay. So, as this younger child comes in the high risk category, it's always advisable to start oseltamivir. And what is your opinion about giving chemoprophylaxis to all the household contacts when a child in the family has influenza proved positive on the throat swab?
Basically, high risk contacts like the infants less than 2 years of age and the pregnant lady or the elderly, those are more than 65 years of age, should be given chemoprophylaxis for 10 days.
Right. So, thank you, Dr. Sevaranjan, for all those crisp and clear answers. And we all now are aware that influenza is a fast and a furious virus with abrupt onset, high transmissibility, rapid progression, even to the extent of development of ARDS. And that is the reason why we also should act very, very quickly. In addition, we should take preventive measures like SMS, that is sanitization, mask, and social distancing, along with following etiquettes related to cough, for example, coughing in the elbow, and also following certain rules related to the hand, which I call as Hasta Pancha Sutri, which includes frequent hand washing, avoiding handshake, use of handkerchief, and keeping others at a hand's distance, and also avoiding hand touching. Remember that influenza virus not only spreads by respiratory droplets, but it also goes and sits on the surfaces of the tabletops, the laptops, the staircases, and doorknobs, and that's why it is important to follow all these instructions. Okay, and also remember to take flu vaccine. The health related people like the pediatricians, the resident staff, the staff nurses, all are very much exposed to the influenza virus, because as we see, children directly cough on our faces when we are examining them, and many of us are not very careful in wearing the masks. Okay, so it is prudent to take this flu vaccine every year, and I always say that happy birthday to you and happy birthday to flu. Both these sentences must come out in the same breath, and rather than celebrating the birthday, or in addition to celebrating the birthday by cutting a cake, it is better to get yourself pricked by the flu shot, because every year the strain changes, and that's why it is important that you protect yourself with the flu vaccine. With this, I say namaste to all our listeners, and also to Dr. Sevaranjan, and of course in our day-to-day practice also, let us learn to shift our habit of shaking hands to saying namaste, so that from our side at least, we will, reduce the transmission of these viruses to others. Thank you very much.
Thank you, sir. Thank you very much. Thanks, Dr. Sabaranjan, for taking time for this. Thanks all the doctors who took time from their schedule and attended this. You can log off, sir. Thank you so much. Wish you a very pleasant evening. Good night.
Any
Thank you.
question is there?
No questions. Sir, एक तुम्हाला सांगायचं राहिलं. I am 1956 trained.
Okay. That's very good. And so you do not look to be 1956 trained. But then you are protected against,